that are not ISPN member, we have the privilege and pleasure to help you. There is the basic requirement, and any doubts, you can contact us. And to have a certificate for this webinar on trauma, please fill the questions, the MCQs at the end of these webinars, around 2 hours, and you will receive this certificate. And please, Jeffrey will introduce the guide, ISPN guide, and Noor Maria will introduce our very important speakers. Thank you and welcome, everyone.
Thank you, Nelci. I'll be brief. It's great to be here. This is one of 3 major initiatives that ISPN Education Committee does. Every month, we do a webinar for junior doctors. Every quarter, we do a controversy discussion called Clash of the Titans. And then about 8 to 12 times a year, we actually visit different places around the world to do live courses. So that's the direction that your ISPN Education Committee is going for the next couple of years. The guide is one of several materials available to you for free. It's on the ISPN website. It is very actively under Rick Abbott's directed refinement and growth. The notion is that it's like a textbook, but not one that has a lot of words. The notion is to give you a very practical source of information. So if you're seeing a patient with a problem that's pediatric neurosurgery, that has to do with pediatric neurosurgery, you can go to the guide. It's on the ISPN website and find small chapters with very practical information to help you manage those patients. So with that, I'll turn this over to Noor so that she can introduce Guirish Solanki, our first speaker for today's trauma symposium.
Thank you very much. Thank you very much. Greetings to everyone and welcome to the webinar. It's our 6th module. I'm really pleased to introduce our first speaker, Dr. Guirish Solanki. He's a pediatric neurosurgeon based in Birmingham, UK, and he's the chair of the Pediatric Neurosurgery Group and also the Neurosurgery Training Committee and the TPD. So we are really pleased to have him with us today. Sir, thank you so much for accepting our invitation, and I want to invite you to start your presentation now.
Thank you, Maria. Really appreciate that. Nelci, Jeffrey, thank you for giving me the opportunity to share with you some of the information that we have on pediatric trauma prevention and epidemiology. Are you able to see my shared slide?
Yes, perfectly. Thanks.
Perfect. Okay, because for a moment, I think it had gone off. So, as you know, I'm delighted and privileged to be part of the ISPN Medical Students and Residents Trainee Education course. It gives me great pleasure, really. And I will start by, telling you that my presentation is going to be more of a neurologist rather than neurosurgeon. I'm going to leave my colleagues to do the neurosurgery today. And what I wanted to tell you is the story of traumatic brain injury as it is unfolding in the last sort of 5 years, particularly. And it all started with the Lancet Commission. And the Lancet Commission and subsequent studies, and we got some real giants in head injury that have been helping us. What we are discovering now and recognizing more and more is that of all common neurological disorders, traumatic brain injury has the highest incidence and poses a substantial challenge to public health. It's not just that little knock on the head, but it's what happens after, what happens to the families, what happens to the environment. So all of that is now being recognized that traumatic brain injury actually is a chronic disease with long-term consequences and with increased risk of late onset neurodegeneration, Alzheimer's, and so on. So the commission, the Lancet Neurology Commission on Traumatic Brain Injury in 2017 called for a concerted action to reduce the global burden of traumatic brain injury. And I want to focus a little bit on that because that background is, concise, consistent, is driven apart, has given us resources on how to achieve, how to get there, and then there is a goal as well. And I can tell you that in the last 5 years, from 2017 to 2022, there's certainly been substantial progress. And I also want to tell you a little bit about what have we done to prevent head injuries. So because that's the main reason how you get traumatic brain injury. So there are, of course, lots of things that we haven't done yet, and a lot of the real advances have not reached clinical implementation. And there is this massive north-south divide of poor and rich countries. And I wanted to tell a little bit about that rather than focus only on the place where I live in the UK. So the first thing is this Lancet Neurology infographic. Just to tell you, this came out in 2017. And, I'll divide that into pieces because it's too big. So 50 million people suffer from a traumatic brain injury worldwide every year. Over 80% of those are in developing countries. The annual global cost of care exceeds $400 billion. And in developed countries, traumatic brain injury increasingly affects the elderly and children under 4 years old. So that's where we come in. And 57,000 traumatic brain injury related deaths and 1.5 million hospitalizations occur just in Europe every year. So what can we do about that? So the Lancet Commission has made 3 specific and large sectional recommendations. One, to apply existing knowledge to improve prevention in clinical care. The second, recommendations to develop a common language for epidemiology and benchmarking care. And the third, recommendations to advance knowledge, clinical care, and outcomes through research. So the first one, improve prevention in clinical care. I think we're all aware that, you want to get the patient with a head injury urgently to theaters, and you want to assess, to put the patient out of harm, and then try and improve the acute and post-acute care. So all of this, then there are, of course, national guidelines for medical and surgical care, rehabilitation, clinical care recommendations. So all of that is actually already available, but how much of it is used and how much of it is practiced? And a clear example is this. Just 2 days ago, Iran goalkeeper, right at the beginning of the game, had a concussion, yet the guidelines clearly state immediately remove from play any participants in sport from a suspected concussion. And yet this chap, unfortunately, went back to play for several further minutes, worsening his concussion before he was ultimately taken out of the game, and he's now in hospital recovering. So these are the sort of things that, we are aware, but we're not acting on it. And this is FIFA guidelines. So I think, we need to kind of ask ourselves, are we really doing this? The second one was about epidemiology and benchmarking care, so that we all speak the same language of research so that we can improve data collection and define measures and outcomes better. And the third one was to advance knowledge, clinical care, and outcomes through research. And there is a lot of research going on, and I'll tell you a little bit about it, but I'll leave that right for the end. In the UK, the National Collaborating Centre for Acute Care, again commissioned by the National Institute of Healthcare and Clinical Excellence, which is NICE, made a sort of wide-ranging review. So 20% of all the referrals, approximately 500,000 A&E attendances, between 2000 and 2001, 100,000 and above were head injuries. And interestingly, 3/4 were male admissions. So we know that boys are significantly more affected than girls when it comes to head injuries. 1/3 less than 15 years old. So 1/3 of all head injuries were in pediatrics. 4,000 neurosurgical operations in total, including pediatrics. Annual incidence of death secondary to head injury between the 6 to 10 per 100,000. And 90% were minor head injuries. 10% moderate to severe head injuries. So that's pretty much the statistic here. And I'll show you the statistic around the world as well. Sorry about that. So head trauma in child abuse. So this is particularly where we're concerned, and my other speaker colleagues today will dwell into this in detail. I will just simply talk about epidemiology. So this particularly, the most common cause of mortality and morbidity in physical child abuse intracranial injury affects about 60% of the inflicted injuries to children. So of course, when children are beaten about and abused, it's not just in the head, it's throughout the body, but in 60% head injury accompanies the physical abuse. 1/3 to just over half of the brain injuries in children at 1 year of age were inflicted. So very high suspicion when a child comes in with a head injury, a fracture, that there may be inflicted head injury. More than 80% of deaths from head trauma in children under 2 are the result of AHT, abusive head injury. So, but the main reason, as you know, is the anatomy of the infant. We have, what we call a very soft skull. The sinus is right abutting on the skull. And then there is this subdural space where the bridging veins from the cerebral cortical vessels cross the subdural space and enter the sinuses. And then when there is any shaking or any violent motion or sudden impact, where there is significant sort of asymmetric or disconjugate movement between the skull and the brain, so the brain is moving but the skull is not, this vessels tear and cause acute subdural bleeding, cerebral thrombosis, and the whole litany of injury to the brain as well. So what is the state of the incidence of traumatic brain injuries and what causes them? So let us see in low income and middle income countries first. So look at this. This is a graph that comes out from a very large paper, again published in the Lancet. So you can see that the 4 main causes which have been investigated here indicate that road traffic accidents overwhelmingly the biggest cause of traumatic brain injury in low-income and middle-income countries, followed by violence, and then falls under 3. And if you look in high-income countries, it's the opposite. Falls account for more than half of the causes, of the etiology of traumatic brain injury, while road traffic accidents is significantly reduced to just about 1/4. Violence is actually only 9% and other causes 12%. But the global impact of all of this still remains significant. So the incidence, worldwide incidence rate per 100,000 in 2019 was 346. The number of people who have traumatic brain injury worldwide remains high, from 50 to 60 million between 2017 and 22. Years lived with a disability worldwide with traumatic brain injury, 8.1 million. 90% proportion of traumatic brain injuries are categorized as mild. So if you want to prevent head injuries, then you want to start looking at road traffic accidents in low middle income countries, because over 50% of the deaths are vulnerable road users. Cyclists, motorcyclists, or pedestrians are the main people who die from road traffic accidents in low middle income countries. 93% of deaths occur in low income. Of all the deaths in traumatic brain injury, 93% come from low middle income countries. Okay, so that's what we're talking about. So there is a lot of things that we can do. For example, if you want to save lives worldwide, drink driving, stop drink driving, use helmets, reduce speeding, seatbelt use. So these are very simple interventions which prevent head injury. And here's the numbers that would come down. You can also look at this by countries, and you can see the enormous impact that interventions can have. In China, for example, speeding is a huge problem, but in other countries, it's either drink driving or other causes. This infographics can be downloaded directly from the Lancet. I've done that myself. So when you look at road traffic related deaths in low middle income countries, 90% are related to the road traffic accident, but 60% occur within the first hour. 30% occur between 1 to 24 hours, and only 10% will occur after 24 hours. So of the 90% of the deaths that occur in the first 24 hours, 60% will die in the first hour. So you've got to intervene really quickly. And of course, as you know, in low middle income countries, the hospital systems are not supportive. So this is where, implementation can be very helpful. but it probably not possible. So there are multiple ways that people have been trying to reduce deaths in low middle income countries. These are some examples. So you can either implement a complete trauma system, which might be very difficult, but even if you try to make available trauma teams to 50% of the road traffic injury victims, you could save 60,000 people. All right, so between 200,000, 6,000 people just by implementing trauma access, trauma teams to support road injury patients. Okay, so there is a road safety movement now which is trying to tackle this over the next 10 years. Okay, these are the 10 points that they are working on. Now, I'm not go into a lot of detail because there's a lot of other stuff that needs to be talked about. I'm going to focus a little bit on children and adolescents now. And so coming back to where I live in a high-income country, the problem here, as you can see, is falls. So what have we done to prevent falls? So here, I just wanted to give you two examples of what we have done to prevent falls. So this fall-related traumatic brain injury. When do falls occur? So we looked at 12,268 emergency department admissions in our hospital, and we wanted to see how many of those are falls. And we looked at a period of 5 years, and then what we found is only 15% were due to actually motor car accidents, and the majority actually was falls. 63% of admissions in males and 41% in females were due to falls. And so we looked at 12,000 patients, 9,589 as a result of falls. Again, more boys than girls, as you can see here. Look at the age range. 1 to 3 is the largest incidence of falls. 3 to 5, 5 to 12, very similar sort of incidents. But this is the group from 1 to 3 to 5 to 12. Preschool going children suffer the most, and then school going at the early age. And when you look at the seasonality, it's mostly in the summer months. When the temperature gets hot, people open their first floor windows and the kids fall off their windows. That's a common finding that we had. Here you go. In the warm months, the falls are significantly greater. And then 79.5% of all our admissions suffering head injury were due to falls. The 1 to 3, 5 to 12-year-olds were the commonest group of children affected. Boys suffered more than girls. And then this is just to tell you, when we looked at when do these things happen, usually in the afternoon or evening, and hardly ever in the morning because they're all in school. But when they come home, this is when it happens. Seasonality, we talked about that. And you can see here, May, June, July, these are the months when it occurs. So we've got some very good data to show that in the summer, falls tend to peak. Boys fall more frequently than girls. Preschool children have the highest risk of falling. So we can start a preventive and education initiative, including a program of awareness that may help reduce frequency and severity of traumatic brain injury in these children. But who do we target? Do we do the whole population? So then we did another study, which is traumatic brain injury, looking at indices of multiple deprivation and how does traumatic brain injury differ. So what we found here, I don't know if everybody's aware, but in the UK, we have this indices of multiple deprivation. So the index of multiple deprivation combines a number of factors like economic, social, housing issues, and gives a single value. And that value tells you where you are. And it's called the lower super output areas in England. So parts of England can be very rich, parts of England can be really poor. And the index of multiple deprivation can identify from where you live, from your postcode, and which area you come from. And the range is from 1 to 5, 1 most deprived, 5 least deprived. And these are the sort of domain weighting. 72% is to do with education, health, employment, and income. And when we looked at the 12,000 patients that we had seen before, and we said, okay, let's see how do they classify into this group of deprivation. And this is what we found. Overall, a large number fell under the most deprived, patients with falls particularly. So this is children with falls are in orange. So you can see quite clearly that the least deprived and the wealthier you were, the least falls you had, and the least and the most deprived and the poorer the area, the greater the number of falls. So there is a direct correlation between falls and poverty, poor education, and lower opportunities. When we looked at the severity of the head injury, again, we found that those children that had more severe head injuries also were in most deprived areas. So children from deprived areas are disproportionately represented in the traumatic brain injury category in all severity grades. Preventive and education initiatives should be targeted to those families living in deprived areas with the greatest chance of benefit to reduce falls. I'll just show this slide to show that the other significant factor is what we call intimate partner violence. That means home or domestic abuse. And that, of course, affects children very badly. Child maltreatment, including exposure to parental partner violence. But there is no policies right now for the preschool and middle childhood to protect them. And this is a huge gap in the way that we treat children. And I just want to bring to your attention that we need to start developing policies to protect children from abuse. And then, of course, I'm just going to summarize this now because I want to give time to the others to talk as well. So key areas for future research: understanding mild traumatic brain injury. That's the important thing. What happens to these children and what can we do about them? We need to classify head injuries much better. We're not doing that right now. Ensuring future research. There are also, of course, other areas. And my great thanks to Mars and colleagues who have done, Menon, Manley. They've been at the very forefront of head injury management. This is one of the pyramids which talks about this holistic approach to head injury. So it's called the BPSE model. You'll hear this name again and again now. It's bio, psycho, socio, ecological model. And it is about outcomes after traumatic brain injury. So there is the biological aspect, which is brain injury severity and host response. There is the psychological aspect, which is coping skills and mental health. Social aspect, social support and employment. Ecological, health-related systems, all starting with the traumatic brain injury. And the summation of all these factors will then result in an outcome. So I want to thank, all the children that participated in the studies, the trauma network, my colleagues, as usual. And also, I don't want to forget to invite all of you to Singapore next week. And thank you very much for listening.
Guirish, that was a great talk. I would just add one thing. The role for neurosurgeons as advocates is growing and growing, and it's one of the most important things that we can do. And it's a role where junior people who are learning all of these difficult procedures can play a very active role. And I know that a number of our colleagues like Tony Fagaji and Andrew Reisner, as you alluded in your talk, have been central to a lot of these efforts at improving vehicular accidents, road traffic accidents, intimate partner violence. And I would just encourage to the young listeners, don't undersell your capability to make a difference in the advocacy domain because it's growing and growing in organized neurosurgery. Nelci or Noor, did you have any other comments or questions?
Yes, thank you very much, Guirish, not only for the excellent lecture, but advocacy for the prevention, and also included the brain trauma on this holistic way, bio-psychosocial economical model to treat. Every country can, in some period, maybe have such details for the data you have in UK. If you know where is the problem, you can act. We are doing the background since now, try to find out where is the problem and to act after. But thank you very much, excellent. And Noor Maria, you can introduce.
Thank you very much for the wonderful lecture, sir. I was just thinking about the concussion thing, sir. I've heard that the quarterback, Brett Favre, has a history of concussions, which nobody has surpassed till now. He was an NFL quarterback, and he suffered the most concussions. And the other example is of Tom Brady, who has a career of 23 years, and he suffered from concussions, but he never gave up. During the playground, he never gave up. He just kept on playing. So rightly you have mentioned about concussion and about sports related concussion. And again, so thank you so much for the wonderful talk. And like you have said, it is a silent epidemic of the low middle income countries. Because I belong to Pakistan, it is very important for us. We see these patients every day, and it is like a silent epidemic on wheels that is killing us. Thank you again. So now I'm pleased to introduce our second speaker, Dr. Jehuda Soleman, who is a senior physician neurosurgeon at the Institution University Hospital, Basel, Switzerland. Dr. Jehuda will be talking about extradural and subdural hematomas. So, Dr. Soleman, are you here?
Yes, thank you very much.
Thank you so much. Yeah, so thank you so much. Welcome to the webinar. You can now share your screen, and the floor is all yours now.
Do you see my screen?
Looks great.
Good. Yes, thank you very much also from my side for the invitation. It's a great pleasure to be here. Happy to join this education course. So I'm going to talk about subdural and extradural hematoma management in children. We'll start with extradural hematoma. It's defined as an accumulation of blood between the skull and the dura, usually referred to as epidural hematoma, and it is usually associated with a fracture and a rupture of a dural artery leading to this bleeding. In children, 30% of TBIs is epidural hematoma, and as you heard in the talk before, most of the patients are male, and the average age is about 10 years old, and usually it's an emergency. It doesn't always have to be an emergency, but usually it is, and if it's not treated, it can be fatal. Looking at the mechanism of extradural hematomas, as mentioned also before, fall from heights, about 1/4 fall from bicycles, vehicle accidents, and very rarely non-accidental. Most of you know that in adults we have the typical lucid interval where the patients are well, then they are comatose, and then they are good again, and that is something that is rare in children. Sorry, they're comatose, they're good, and then they're comatose again. Suddenly, that is quite rare in children. Children have milder symptoms. They have headache, drowsiness, limb weakness, diplopia, and seizure, and then at some point they might even get comatose. Usually, as you saw, 90% of brain traumas are mild traumas, and also when the kids have an epidural hematoma, it might be a mild trauma. And then there's always a discussion: should we put them in the ICU? Should we admit them? How long to admit them? And there are some nice scores out there which were published, and you can see that depressed skull fracture, midline shift, epidural hematoma per se, and the Glasgow Coma Scale of 13 or 14, depends on the Glasgow Coma Scale, you get points, and when you add up these points, exponentially the risk of undergoing surgery or of deteriorating is higher, and therefore above a score of 2, it is recommended to put these patients in ICU and follow them for at least one night in the ICU. There are also other scores, like the kids TBI score. I won't go into it, so you can look it up, and this is also a score that helps the decision if to put patients in the ICU and how to follow them. So when we have an extradural hematoma or epidural hematoma, which the patients are neurologically, they show neurological sequel, then usually the treatment is surgical. The gold standard is a craniotomy and removal of the hematoma. And there are some special things in children. So first of all, not every epidural hematoma in a child needs surgery. And once we do surgery, I would recommend, especially in small children, to use resorbable material for bone fixation. These are resorbable craniofixes, or you can also use sutures. Remember that the child head needs to continue and grow, and if you put titanium plates, you might end up needing surgery again to replace the bone which is dislocated because the head is growing. And the question is also when can we treat these patients conservatively? So there are some papers out there showing that if you don't have a mass effect, if the volume is under 15 cubic centimeters and no neurological deficits, you can watch these patients in the ICU, and many of them won't need surgery. Some authors even claim that the size is not what matters, but it's more neurological deficits and mass effect. So keep in mind that not every epidural hematoma you have to rush the patient into surgery. The next question is, how often should we scan? If we treat conservatively, should we do a scan every 6 hours or every day? And if we operate, do we need routine scans after surgery? So there's also here a nice work done where you can, the INIT CT score it's called, and there you can decide, especially for conservative treatment, when to do CT, when to admit, and how long to observe. So our practice is usually, if we do it conservatively, we do after 6 hours, one scan in pediatric patients, and then we follow them clinically if they're stable, and if the CT is more or less stable, we follow them clinically and then decide by clinical condition. If we operate the patients, then we usually don't do a routine postoperative scan. And if the patient is fine, we just follow them clinically. Of course, if they deteriorate, then I would recommend to do a scan. I just want to show you two cases of extradural hematomas or epidural hematomas, which are quite different from one another. So this case is a 3-year-old boy. He fell from his bed. He was sleeping next to his mother and fell. She didn't notice him falling and heard the sound. And then during the day, it happened in the morning. During the day, he was sleepy. He vomited once or twice, but the mother thought it's okay. And in the evening, when he was sleeping, she tried to wake him up, and he wasn't able to wake up. So they called the ambulance. When they came, he was in a GCS of 3. He had bilateral non-reactant pupils. They got quite fast to the hospital, but when he came, it was already half an hour with bilateral non-reacting pupils. Now, for those of you coming also from the adult world, this is alerting, of course. And sometimes in adults, we would say if the bilateral non-reactant pupils, we wouldn't do anything anymore. In pediatric patients, it's different. I would recommend always to try and do surgery and save these patients. So you see this large epidural hematoma, also with the uncal herniation, causing the pupil reaction. And we took the patient for emergency craniotomy, removed the hematoma, and inserted the ICP probe. And we decided during surgery to put back the bone, which was probably a mistake. One day after surgery, we had to remove the bone again because he didn't recover very well. And he developed postoperatively on the 9th day. You see here a large hygroma where we put the subdural drain, which got infected. To make a long story short, at the end, he needed a subdural peritoneal shunt. We put back the bone after 23 days. The patient went to rehab and is now recovering well. Probably at some point we will be able to remove the shunt again. So you see, this is a case of a very dramatic presentation, and the patient is awake and is doing good. So I would recommend to go for surgery in these patients, even if from the adult world we know something else. The second case is a newborn which had a very traumatic birth. He was they didn't manage to get him out well. They used all kinds of measurements, and he ended up having a fracture and a cephal and subgaleal hematoma, and also this epidural hematoma. This is one day after birth, and after 14 days, they saw clinically that the hematoma grew. They did an MRI, and the child was clinically stable. The hemoglobin was stable. And this was at a different hospital, and there the surgeons recommended to do surgery on this kid. The kid was doing fine. The parents looked us up and called us for a second opinion, and we recommended to wait and see, to just sit tight and not touch these hematomas, because in babies, blood loss is a big problem. If the kid is doing fine, usually these cephal hematomas and even the epidural hematomas can go away. We recommended to do an ultrasound as a follow-up. And luckily, that's what they did. After 26 days, you see the hematoma went down, and 5 months later, he came to our clinic. He had a full recovery. The hematoma disappeared. the bone is not dislocated anymore, and the baby is doing well and is developing normal. So in babies, you know, there's a little bit more space around the brain because the bone is still not closed. And if the baby is doing fine, don't rush them into surgery. Just have them checked very well in the ICU. And if they deteriorate, then you can still go for surgery. So I'm going to move now to subdural hematomas. Subdural hematomas are defined as accumulation of blood between the dura and the arachnoid space. Just to remind you that the subdural space is actually a virtual space, and it's caused by the bleeding. So usually there's not a real space there. As you know, the dura and the arachnoid are together, and once a bleeding occurs, then the space is created. Usually it's a rupture of the bridging veins, and pediatric trauma is usually acute subdural hematoma, as opposed to adults where we often see chronic subdural hematoma. And in children, even very thin hematomas may cause intracranial pressure, especially when the bone is already closed. And as I said, chronic subdural hematoma is something that is often non-accidental as opposed to adults. The treatment of acute subdural hematoma, if the patient is not doing well, usually we do surgical treatment, and it's a decompressive craniectomy. We tend to do a hemicraniectomy on the side of the hematoma. We open the dura widely, we resect, we remove the blood, and usually we leave the bone out. If the patient is doing good, GCS 14, 15, and there's no signs of pressure, then you could follow. You can do conservative management. We tend to repeat CT also after 6 hours, and if then the patient is fine, we just do clinical follow-ups in the ICU. So this is a case of a 14-year-old. He had a trauma of the bicycle. He came in with a GCS of 7 and an anisocoria on the right side. You see here the small subdural hematoma and the fracture, and the brain is very swollen. As you can see, the gyri are almost not visible. This is a very acute situation with very high ICP, and the patient was rushed to a decompressive hemicraniectomy. We also put in an ICP probe. He had a very good recovery. He had gained full function again, and after 2 months he went to rehab. After 2 months we were able to put back the bone, his own bone, which we put in the freezer, and then we take it out and place it back again. But after a year, he had a bone resorption. As you can see here, the bone resorbed almost completely. And of course, we did a cranioplasty using hydroxyapatite. So in subdural hematoma, when you do a decompression, just keep in mind bone resorption is something that can occur, and it's more frequent in children than in adults. Young age is a risk factor. There are also other risk factors, but young age is an important risk factor. And the problem in children, as I said before, the head is growing. So we can't just use normal PEEK plastic or Palakos plastic as we are used to in adults, but there are still some materials out there that we can use for cranioplasty. One is hydroxyapatite. It's supposed to be osteoconductive, so even if the head grows, the bone grows towards the cranioplasty, and there's no gap which is created, and the bone doesn't dislocate. For small craniotomies, less for subdural hematomas, but for small craniotomies or craniectomies, you can use Norian cement. This is but only for small defects. The cement at some point resorbs and the bone grows into it. Other options are using tutobone. They only come in squares, so you would need to place resorbable plates and the tutobone all around the craniectomy and hope that it grows back together. And another option is using split bone. Of course, if you have a large decompressive craniotomy, split bone is not a good option, but for smaller defects, you can always do a craniotomy, split the bone in the middle, and then place half of the bone here and half of the bone here. This only works in children which are older than 2-3 years, because babies, they usually don't have the spongiosum yet, and you can't really split the bone. And of course, resorbable mesh. which you can combine with tuto bone or combine it even with Norian cement in order that the bone grows back together. So there are some options. I think for the decompressive craniectomy, the hydroxyapatite is a good option. I would say in teenagers, in 14-year-old children, you don't have to use it, but if the children are smaller, then I would definitely recommend to think about using these materials. So when we talk about chronic subdural hematoma, the differential diagnosis in pediatric patients is larger. You have the benign enlargement of subarachnoid space, usually in infancy, in babies. These babies have bigger heads, and usually they come already to the clinic with an MRI because of macrocephaly. You see a little bit of ventricular enlargement. You see this hygromas or fluid, liquid CSF in the subdural space. And just know that this is something that is self-limiting. So you need to follow these patients. If it grows worse, then it might be an external hydrocephalus, but otherwise, usually it goes away. We know that subdural hematoma can be caused by arachnoid cysts, spontaneous bleedings by arachnoid cyst, and non-accidental subdural hematoma. I won't go into this because this is a topic of a different talk, but it's something that happens in children as well, in babies. Shunt overdrainage, which can cause subdural hematoma. And in babies which have traumatic births, tentorial subdural hematoma of infancy. Very rarely does this need treatment. This also is something that is self-limited. So the treatment of chronic subdural hematoma, if we need to treat it, hygroma or a chronic subdural hematoma, then usually we do first a burr hole, 1 or 2. That is still not something that we really know which is better, and a drain for 48 hours. And then if it persists, if we see that the fluid persists and the burr hole drainage is not enough, then we put in a subdural peritoneal shunt, usually on one side, because we know that it is connected and without a valve. That is what we do usually. We can still discuss if anyone puts a valve, but we usually have good experience without putting a valve. And follow these patients because with time, the subdural space closes again. And then usually you can remove the subdural and the shunt if the parents wish to. If the parents want to leave it, you can also leave it, but usually you can remove the shunt after 6 to 12 months. So to conclude, subdural and extradural bleeding in children are, of course, different than adults. The symptoms are different, the causes are different, and the management is different. Remember that the patient's head is still growing. Even if we have bilateral dilated pupils, at times someone will tell you not to treat these patients. I recommend, if it's been for 6 hours, of course, it's a different discussion, but if it's acute, I would try and treat these patients. Acute epidural hematoma, if they're clinically well, you can wait and watch, maybe do 1 repeat CT. If they have neurological symptoms, craniotomy and hematoma removal. Remember to use resorbable plates or sutures, and in infants, you can be maybe more conservatively. Acute subdural hematoma, again, if the patient is clinically well, you can wait and watch, maybe 1 repeat CT, and if they have symptoms, decompressive craniectomy, resorption of the bone, is a big issue in pediatric patients, and if it's possible, use osteoconductive material for cranioplasty. Chronic subdural hematoma or hygroma, if it's a BES or infant tentorial bleeding, then usually we don't need to do anything. Otherwise, first measurement is burr hole drainage with a drain, and if it persists, you can put in a subdural peritoneal shunt, and these shunts usually can be removed. So follow-up imaging is needed, and then discussion with the parents if you want to remove it. Thank you very much.
Thank you very much, Soleman. Excellent lecture. Enlightens the subject, subdural and epidural hematoma. We can try to answer some questions and go to discussion now before the second part. And maybe we can start with the Guirish question. I saw you answer directly to the person, but maybe you can do some comments on mild TBI. They are really mild TBI, or we need to pay attention?
What I can do, sorry. I just want to make sure that, can you hear me? You can hear me?
Yes.
Yes, thank you. I think what I can do is I can just quickly share a couple of slides that show this, because there's some confusion about what does mild TBI mean and what is the impact on survival. So if it is okay, I'll just quickly share the couple of slides that I didn't show them during the presentation because I wanted to stick to epidemiology. But let me just show you this very quickly. Just trying to put it here. Okay, so share. Where's the PowerPoint? Okay, so can you see my slide?
Yes.
So, okay, so there's basically, the mild, moderate, and severe types. They have not gone away, but the ATLS has converted Glasgow Coma Score 13 to mild rather than moderate. So that's the first thing I would say. But the classification that started in 1975 by Teasdale and Janet is there. And what is the importance of this? Look at this, log of that, right? And this is a large series of patients, and Maas reported this in his paper in 2004. And if you look at this, right, number of deaths is in the lower row, and the number of patients in the upper row. And as your Glasgow Coma score gets worse from 15 to 3, even at the Glasgow Coma score of 14, 13, you start getting deaths. Can you see that?
Maybe is the next slide, Guirish? We still on the severity.
We're still seeing the scale slide. Maybe you go on to the next one. It's a good point.
Okay, so I'm not sure what happened. Are you seeing the scale?
Yeah, we see the scale. Can you advance to number 9?
Okay, and now?
Still the scale.
Maybe go to the presentation mode.
Yeah, let me go to presentation mode. Sorry about that.
There you go.
Okay.
Much better.
Can you see it now?
Yes.
Oh, I don't know what happened. Because now I don't see anything in front of me, but if I'm sharing, that's okay. So this is the log chart, the log of odds of death. And on the first row is the number of patients, on the second row is the number of deaths. And you can see that even at GCS 13, 14, which is mild head injury, traumatic brain injury, there is a chance of death. And that exponentially increases to the most severe aspect, which is GCS 3 and 4. So that's why, although we find it important to classify the traumatic brain injuries as mild, moderate, and severe, it doesn't mean that a mild head injury is not associated with mortality. I hope that clarifies that question.
For sure. I think that's a really important point. And I would just turn to, there are several questions about how to deal with the bone in doing acute decompression. One question about timing. One question about conditions for bone graft. And finally, what about the age for a split bone graft? So could you develop a little more, Dr. Soleman, your rationale and treatment of how do you manage the bone graft when you do a decompressive craniectomy or a large subdural removal?
Yes, so it's something that is always debated and discussed, and to tell you the truth, we don't have an answer for everything. Of course, I think to talk about split bone, so usually we have a CT, and in the CT you see if the bone is thick enough to do split bone. If it's not thick enough, then it won't work. The bone will break, and you need to really see the spongiosa on the CT. And in my experience, I would say if the kid is 2 years and older, it should be fine. Then you should be able to do a split bone. This is also for craniosynostosis. When you have a problem with when they don't fuse, etc., you can also use split bone. I think for the decompressive craniectomy, split bone is not a very good option. You could try putting in like strips and hope that the bone in between closes. But I would say the cutoff is like 2 years plus minus. We always try to put the autologous bone back. I know there are groups which put plasty from the beginning. Still, I think if we have a 50% chance that it will function with the own bone, I think it's still better than putting something else, especially in children. So I wouldn't recommend to just throw the bone away and put a cranioplasty. And in my experience, the hydroxyapatite bone is quite good for reconstruction after decompressive craniectomy. The problem is it's quite expensive.
Yes, very much so. Guirish, do you have any comments about bone management when you do an acute operation?
Yeah, so for nearly 20 plus years, what we do is if we have to do large craniotomies, particularly decompressive craniectomies, we take the bone, we cut it in small pieces. It doesn't have to be very small pieces, and we put them in the abdomen. So make an incision in the subcutaneous tissue outside the muscle, and we just, put all the pieces in and close the abdomen. And it's amazing how quickly the bone revascularizes and stays healthy. And so we don't lose any bone. And this is so much better than freezing the bone or even, using, temperature to sterilize it, because I think neither of them can actually sterilize the organic component and the marrow part. So the diplo always remains a source of infection, and you use the cranioplasty sooner or later in those cases. So we put, at the adult hospital where they used to sterilize the bone and put it back, their failure rate was over 50% with cranioplasties. So they moved on to do titanium cranioplasties because of that. And at the Children's Hospital in 20 years, we have not lost a single bone flap to infection by using, maybe implanting them in the abdomen. So I think it does, for us, it's been making a difference, but of course, everybody has a different view and different ways of doing it. So yeah, thank you.
I think it's important for the learners that you hear a variety of different perspectives. These are what sort of in evidence-based medicine we think of as practice preferences. You'll have senior people, you'll go to different meetings and read different papers in the literature, and you'll see different approaches to similar problems. And I want to encourage you not to develop the thinking that one is right and one is wrong, but rather that these are different groups of experienced providers that are sharing with you their individual practices. And it's up to us together to come together to try and evaluate the evidence, to try and using the things of the cornerstones of study design and weight of evidence and things like that, to really see if one of these methods is better than another. And until that time, most all of us reflect on our training and our own individual experience, because sometimes it can seem confusing where you hear different things in different places. Nelci, any comments?
Yes, thank you, Jeff. Just a moment, Noor Maria. We have the same experience to keep the bone in the abdomen. And our experience about split bone below 4 years of age is not good. We lose some childs that the bone, it wasn't good on 3 and 2 years old. We keep now only after 4 years to try to do the split bone. But thank you very much. It's great discussion. Please, Noor Maria.
Thank you so much, Madam. Thank you so much. Madam, I also wanted to add that what would be the role of 3D printed bone prostheses, which are quite common right now. Not very common, but they have been used in adults, the 3D printed bone prostheses. So, Madam, what do you think that will be the feasibility and benefits or possibility in the pediatric patient 3D bone printing?
Jeffrey, can I just add a point? I think, Jehuda made a very important point that we should try and avoid, synthetic, materials, metal. I think this is such a horrible situation for children. And I think every effort should be made to keep the original bone. And I think that's an important point you made there. Thank you.
Sir, there's another thing that is very commonly discussed in the hospital and in the clinical settings. It is the use of the anticonvulsants after traumatic brain injury. Since we know that the AEDs are mostly beneficial for the early post-traumatic seizure and not for the development, it cannot prevent the long-term development of PTE, the post-traumatic epilepsy. While there are certain factors that are more predisposing towards the development of PTE, there are several factors that have been identified, not only the severity of injury, but also the factors, one's own factors that could be there, and obviously the frequency of early seizures. And there is, even if a single delayed seizure can predispose to the development of PTE. So what will be the consensus of all of our speakers and the experience, your experience, for the recommendation of anticonvulsants of the TBI and the duration?
So the question is anticonvulsants after TBI. Is that correct?
Exactly.
Okay. Do you guys want to weigh in? When do you use anticonvulsants?
I know it's a big discussion also in adults, but I don't know if it's correct what we do, but my experience is that it's not as frequent, and we usually don't give anticonvulsive, like empirically. Only if we think that the patient had a convulsive seizure, then we treat them. But otherwise, we don't give it like prophylactically. That is
even if
my
there's
practice.
Blood or no blood, does the presence of blood make a difference?
No.
Okay.
No, in my practice,
no
not.
Anticonvulsants in Basel.
No.
In the pediatric world.
Sorry?
For children, no, you use
no. We don't give it prophylactically. If we think, and the neurologists think they had a seizure, then for sure. But we don't give it to every patient that has blood in the brain. Yeah.
Romina, you haven't spoken yet. You haven't given us your talk yet. But if you're on, can you share with us what you do with anticonvulsants and trauma? Don't know.
You asked to Romina, Jeffrey?
Yes, if she has. Romina, how do you use anticonvulsants in trauma in children?
Okay, hello, good afternoon all. In the Guirish Hospital, we can take the
Probably the internet goes down.
Looks like it went away. I'm sorry.
Okay.
How about it, Nelci? What do you all do for anticonvulsants?
Yeah, I think anticonvulsants and corticosteroids, it was regularly 20, 30 years ago. But since we have more and more guidelines that we have more complications than prevention, I think it's no place anymore to deliver anticonvulsants prophylactically at the moment. Come back, Romina.
Right. Hello.
Hey, there we
Okay.
Can you hear me?
Don't
Yes.
worry. Yes, please.
I am in the hospital right now, and the signal of internet is very bad. Okay, the question.
Do you
Prophylactic
use
anticonvulsants on brain trauma?
No, in
Okay.
the Guirish, no.
Thank you.
And just for another point of view, if we do make a little difference, if there's blood below the dura, a small subdural, something like that, we'll provide anticonvulsants, something simple like Keppra, for about 7 to 10 days. There is data that shows that short-term anticonvulsants prevent seizures, but not long-term epilepsy. And we've used that to convince us to justify the decision that we give them just for a short period of time. It does not prevent long-term epilepsy.
With electroencephalography control, Jeffrey, or just prevention? Does it matter
Just prevention.
if there is or not seizures on the EEG?
It's given empirically.
Okay.
Madam,
Yes.
there is also another growing interest in the double lucid interval, because one of my own trainees once questioned about the double lucid interval. This is interesting because we usually talk about the lucid interval, but we do not talk about the double lucid intervals that much frequently, not seen very commonly. Sometimes things have been missed. I think that we should also mention about something about the double lucid interval.
Sounds good.
Yeah, exactly. Sarah, I think that there are press reports from the posterior cranial fossa with the double lucid interval where the patient was, deteriorated just to recover again, and then he deteriorated again. So this is something that was of interest for one of our trainees. He came up with this question a few days ago, and I was just thinking that we are going to conduct this webinar. So I think that it's worth mentioning the double lucid interval, because this is something which is very fascinating for the new trainees to listen to, because they know about the lucid interval, but not about the double lucid interval, which is quite important. I think that we should basically rely on about the mechanism of injury and about the presentation of the patient, and we should suspect that what could be there. There are several patients in our part of the country. Several patients come from the far-flung areas where sometimes we cannot get them in time, and sometimes we do not have the right history and right mechanism that we know what happened to that patient that way. So again, thank you so much for the wonderful discussion and wonderful lectures, of course. Madam, should we?
Some more comments, Guirish, before moving to the second. Thanks, Maria, for your contribution.
I was just going to say that, just like Yehuda was saying, we don't use anticonvulsants prophylactically, but one exception is, as Jeffrey was saying, is when there is significant blood, and particularly when there is intraparenchymal blood in areas that we know could be related to, epileptic sites. In those cases, we would give prophylactically. And, it's just a lot of this is not science, is a lot, your gut instinct in this situations. The problem is once you start, and this is why we don't give it empirically. Once you start, then you don't know when to stop. And sometimes the kids don't get better immediately. And then you continue it for months and months. So we just try not to start. But if there is hemorrhage, or a lot of the children with NAI, they are, I think, more prone to getting seizures. I think they tend to get a greater frequency of empirical anticonvulsants.
Thank you very much. We have more questions on the chat. Maybe we can go to the second part, and at the end try to answer as much questions we can. Please, Noor Maria. Oh, Jeffrey?
No, I was just going to say that Andy Reisner had to go do some trauma, so he's not able to join us. So we will move on to the latter two talks, and Noor Marie will introduce our speakers.
Thank you so much. I'm really pleased to introduce our next session. And the first speaker of the next session is Dr. Rumima Argonores. She works at the Garahan Hospital, Buenos Aires. She will be delivering a lecture on non-accidental trauma. Dr. Rumina, thank you so much for joining us today. We are really pleased and honored to have you with us today. You can now share your screen, and the floor is yours now. Dr. Rumina, I think she has.
You are muted, Rumina. Just unmute yourself.
Sorry.
Thank you.
Very good.
Okay.
Very good. Much better.
You can see my presentation now?
Not yet.
Just you, yes.
1 minute. Now, no.
Not yet.
I don't know why.
You're still having trouble.
In the middle, bottom green one, share screen or compartilhar tela. Doesn't work? If don't worry, you have time. We may switch to Lina and come back to you if you prefer.
Okay.
Or you can
Yes.
try again if you want.
Thank you. Okay.
Don't worry. Happen time to us too. Don't worry.
To all of us. Yeah, don't worry about it. Nor Marie, would you like to introduce
Yes,
Dr. Lynn Lucina?
Yes, thank you so much. I'm really pleased to introduce Dr. Lourdes Navarrete Lucena. She's the pastor of the Philippines Board of Neurosurgical Examiners and the president of the University of the Philippines Faculty Alumni of Neurosciences. She's a member of Women in Neurosurgery Committee as well as the World Federation, the World Federation of Neurosurgical Societies, WHO Liaison Committee, and she has been recently declared the chair of the WFNS Trauma Committee. Dr. Lynn, can you hear us now? I hope she's here.
Yeah.
Thank you so much,
yes.
Dr. Lynn. Thank you so
Okay.
much, Dr. Lynn. It's really nice to have you here with us today. You always deliver. You've been really active in neurosurgical education. So welcome to the show.
So it's good morning from the Philippines. It's 1:10 a.m. here. So I'm very pleased and very grateful for the invitation to be here and teach something about spinal cord injuries. So let me just share my screen. Wait, let me just... do you see it now?
Yes, you can try to open the PowerPoint first.
Yeah, I will. Let me just check. I will just
Madam, you will have to switch to the PowerPoint. We can see your document. We
you
cannot...
see.
Yes, your
Wait,
document.
let me just check. What's happening?
We are seeing your computer.
Yeah.
Okay.
Just open your PowerPoint and should be okay.
Agreed.
Have you
Okay.
opened? Is your window of the PowerPoint open already?
Yeah, it's open here.
Okay, so just try to cancel. Try to unshare your screen and then share it again and select the PowerPoint. I think.
Okay. Wait,
Yeah.
I'll stop it sharing first.
Yeah, there you go. Stop share. And then
Okay.
share again. And
Here.
options. Click on your PowerPoint. There
Can
you
you
go.
see it now?
There.
Exactly.
Yeah.
Yeah, exactly. Perfect.
Okay. So now I have to go to the slideshow, right?
Yep.
Yes.
On the bottom. Yep. Exactly.
Yeah. Wait, let me just...
There.
Yes.
Try that. Oh, no,
No.
next one.
The next one.
This one.
Next one.
Yeah. Okay.
Yes.
Try that.
Yeah.
Perfect.
Very good. There you
Great.
go.
Okay. So now I'm discussing actually spinal cord injuries, but I think I'll be focusing more on spinal cord injuries without radiographic abnormalities, or what we call the Shihara. Okay. So let me just okay. So now disclosure, I am very grateful for the organization for the invitation, and no other disclosures. Okay, so outline of the lecture, I will be defining what Shihara is more specifically, and also how to diagnose and what is the usual presentation and the management and treatment and the recent literature. Okay, so Shihara actually, as I already mentioned, a spinal cord injury without the radiographic abnormality. This was actually defined by Pang and Wahlberger in 1982. So they said that clinical symptoms of traumatic myelopathy with no radiographic or computed tomographic features or spinal fracture or instability is what we term as Shihara. The first case was documented in 1974, but Pollack in 1995 actually found out that in his series of 617 children, the incidence even rose up to 36%. So what is quoted here, the Shihara does not actually include the spinal cord injuries from the electric current or electrocution from obstetric complications or congenital spinal anomalies or penetrating injury to the spinal canal. So overall, what are the typical spinal cord injuries in children? You can usually have your occipito-atlantal or atlantoaxial dissociation. You can have your atlantoaxial rotatory subluxation, or you can have what we will be discussing like Shiwara, or you can have your multiple thoracic compression fractures. Spinal cord injury in children actually out from this several studies, it ranges from 2.7 to 9% in incidence. And most of them at 40 to 60% is at the cervical area. So when you differentiate cases, whether it's Shiwara or not, other differentiations would be your non-traumatic degenerative changes, acute traumatic injuries. But some authors would say that spinal cord injuries without radiographic evidence of trauma, since they sort of segregated the trauma causes, is termed as Shiwara. Okay. So why is this happening more in children? So according to Basu et al., number one, the differences is that the facet joints of the children are more shallow and horizontal than the adults. And the ligaments and the capsule are more stretchable without tearing. And the uncinate process is absent in children, and the vertebral bodies are more wedge-shaped. They're not that developed yet. And spinous process are less developed. So again, discussing the physiopathology, the incidence is 6 to 19% in children of this Shiwara, and adults can be 9 to 14%. But the highest would be in children of less than 8 years of age, in which case, if it happens, since this is the most common age group, because of this causes, okay, the ratio of the head to the body is that the head is bigger, okay, and heavier, and the neck muscles, as we mentioned, are weaker, not yet that developed, and there's greater elasticity of the vertebral ligaments, and you have the horizontal orientation of the facet joints, and the blood supply to the cord is not that developed, or it's still tenuous, okay. So meaning that if you have temporary occlusion of vertebral arteries in which the, for example, the cervical area snaps, there's a hyperflexion and hyperextension, in which case there's a temporary occlusion of the vertebral arteries. It can result to contusion or ischemia of the spinal cord, but there would be no radiographic abnormalities like fractures. Okay, so as I mentioned, so a hyperextension or hyperflexion, it can also happen from direct frontal impact on the face. So in adults, this could happen from diving, rugby, wrestling, baseball, low energy falls in the elderly. But in children less than 8 years of age, I mentioned it's mostly in the cervical spine, mostly above C4, motor vehicle crashes, falls, and child abuse. It can even happen with extensive shaking of the child. Okay, and in children of more than 8 years of age, the more common is the lower cervical areas like C5 to C8. It can still happen in motor vehicle crashes, sports, and diving, gymnastics, American football, wrestling, and horseback riding. So as we mentioned, there should be a high index of suspicion. It says here at the bottom, spinal cord injury should be suspected in any child if there's already a history of fall more than or equal to 3 meters, if the child has been involved in motor vehicle crashes, and if there's submersion injury. So what can be the possible diagnosis or presentation? There could be as simple as like lancinating pain from the spine and extremities. There can be transient paresthesias or even tingling and weakness. In 25% of children, the onset of neurologic signs can be delayed. They may not be there right after the injury, or the partial deficits or the complete paralysis can even happen from 30 minutes after the injury to even 4 days after the injury. So diagnostic modalities consist of your x-rays. You can have your cross-table lateral, anteroposterior views, your open mouth odontoid views. So they said that even if you have your lateral spine x-ray, like a cervical lateral, you can already identify 75% of the fractures with 85% sensitivity. But this can increase to around 90% if you have all this, like anteroposterior, the lateral view, the oblique, and then your open mouth and odontoid. So to test for your stability, you can do your flexion extension dynamic x-rays in the older children. Okay. And of course, you have your CT scan. What does the CT scan detect? This will already show definitely if you have your fractures, the bony structures, okay? And the confirmation now in the advent of the MRI, it is tantamount to being diagnosing whether there are small hematomas or transections even of the spinal cord. But they also coined certain instances in which the MRI was even normal. So they term it as a spinal cord injury without neuroimaging abnormality. So it can be that the patient or the child has symptoms, no? Transient weakness or even paresthesias, but even the MRI can be normal. But still, this does not prevent you from diagnosing the patient with that term. Okay. So what is the treatment for these cases? Usually, they recommend external immobilization for 12 weeks or 3 months, and generally the patient has to avoid increased risk activities for the next 6 months. Very important is to maintain the oxygenation and spinal cord perfusion and supportive care, meaning if there is really paralysis, care should be focused on moving the patient so that the cubitus ulcers will not develop, okay? And surgical stabilization when appropriate, okay? But this is not the usual case, okay? But long-term symptomatic care and rehabilitation is very important. So they said that the surgical treatment, it's controversial, especially the timing. But some series has already shown that optimal schedule is 3 to 7 days post-injury. So the longer that you wait, if the patient's already symptomatic and there is possible surgical indication, the prognosis would be not that good or could be worse. Okay. So in a paper by Pang, the initial neurologic status on admission, he said it's the long-term predictor for the improvement of a patient. So meaning the worst neurologic status on admission, for example, if there's complete spinal cord injury, then the recovery is not that good. But if there is incomplete spinal cord injury, then there may be chances of recovering, because mostly Shiwaras are treated conservatively. The surgery, as I mentioned, is not that commonly done. It's only done if there is really the need for it. And the other prognosticating factor are the MRI findings. For example, if, as I mentioned, if there's transection of the cord, then the prognosis is not that good compared to if you just have small hematomas, which can actually be absorbed and resolved. Okay. So before I go, I should mention that some of the post injury complications could be permanent spinal deformities and even development of syringomyelia. So all these things should be addressed. For example, spinal deformities, patient could be wearing braces or could have surgical correction later on, depending on on the predominant defect. And syringomyelia, that could be addressed, although it's very difficult to treat syringomyelia, but it could be addressed with a shunt, okay? If it's continuously developing and leading to increasing deficits, okay? So thank you for your kind attention. I will stop share now.
Thank you, Lynn, for this very interesting lecture. We learned that even if we don't have image to prove that there is something wrong on the bone, MRI, X-ray, and MRI and X-ray, you indicate immobilization for 3 months and avoid sports for 6 months, right?
Yes, the important there is the high index of suspicion, because the patient or the child, you know, like may he have delayed signs and symptoms. So they already are recommending in the papers to have an MRI, even with the high index of suspicion correlating with the history of possible the motor vehicle crash or even fall. So if there's the mechanism of hyperextension and hyperflexion, then there should already be the possibility of getting an MRI, because the patient may develop the symptoms later. Yeah.
Thank you. Jeff, we may move to Romina's speech and discuss after.
Yeah, Dr. Romina is, I think she has joined us again.
Yes.
Okay. Thank you so much, Dr. Romina. It's a pleasure to have you here with us today to present your lecture on non-accidental head injuries. Dr. Romina, as I have already introduced her before, but I'm pleased to introduce her again. She's a neurosurgeon at the Guirish Hospital in Buenos Aires, and it's a matter of great honor for us to have her here today with us to present this very important topic. Dr. Romina, the floor is yours now, and you can just proceed with your presentation.
Thank you, Romina. Are you on? Yes, it's perfect.
Ahí está.
It was.
Okay.
Okay, it's perfect sharing.
Okay, thank you.
Exactly.
Sorry for the delay.
No worries.
Okay.
Thank you, Dr. Nelci, for this invitation. I'm really happy is here with you, and apologize for my English, which is no good. Okay. Remember that the World Health Organization defined the child abuse as all forms of physical or emotional abuse, sexual abuse, negligent treatment, or exploitation. Non-accidental head trauma is therefore a form of child abuse. We can find other ways to call it, such as inflicted traumatic head injury, non-accidental head trauma, shaking impact syndrome, whiplash, shaking infant, and the shaking baby syndrome. The CDC and the American Academy of Pediatric have recommended using the term abuse head trauma. In this case, they have included shock, blunt impact, suffocation, and strangulation. Also include injury from dropping and throwing a child. The term describes the type of injury rather than the mechanism. Most victims of abuse head trauma are under 1 year of age, often between 3 and 8 months of age, but this injury can occur in children of any age. The aggressor is usually a caregiver or the father, and the incidence is very, very high. And most importantly, remember that abuse, head injury is the leading cause of death and disability in infants from child abuse. When analyzing the risk factor, we can say that the behavioral health problem, domestic violence history, frustration, intoleration, lack of child care experience, lack of prenatal care, low education level, low socioeconomic status, single parent family, and young parent without support. These are usually found, but a good socioeconomic level shouldn't rule out abuse as a cause in the face of characteristic finding. Regarding risk factor associated with children, we see that babies who cry uncontrollably are at risk of frustrating caregiving, responding with violent shaking. The colic is a risk factor, for example. Baby crying is reached between 6 and 8 weeks of age, and then decrease. As a consequence, abusive head trauma peaks during the same period. So in this article, the Dr. Di Rocco talked about the role of the neurosurgeon in the non-accidental head trauma. It's not only the treatment of the injury, but also the recognition of a possible situation of abuse, and the related legal implication is very important. Therefore, the neurosurgeon must be able to arrive at the correct differential diagnosis. Among all events, they may share similar and clinical pathological characteristics. If abusive head trauma is being considered, the child diagnosis evaluation is necessary. The evaluation should include complete history, physical and laboratory examination, imaging, and consult with a specialist, primarily the ophthalmologist. Unfortunately, the most severe case of trauma will present with life-threatening signs and symptoms. The responsible person cannot bring the child for treatment for fear or legal repercussion, and the hope that the child will recover in time. Unfortunately, late care often has devastating effect on short and long-term prognosis. We can find apnea, valve function, bradycardia, cardiovascular collapse, chill, decreased interaction, decreased level of conscience, failure to thrive, hypothermia, irritability, increased sleep, light affection, smile, etc. In the upper photograph, we can see human beats and multiple bruises in the lower and in the lower image, retinal hemorrhage in the fundoscopy, and a bilateral subdural hematoma in the MRI. Other findings that can also make and suspect child abuse are bruises anywhere in a baby under 4 years, bruises in the ears, neck, and torso, especially in child under 4 years of age. Frenulum lesion, hydrocephalus, marks of ligation, retinal hemorrhage, fracture on long boards, some it's another finding. Therefore, the image that will help us are the CT scan and the RX survey. In case of Tau, we go reduce an MRI. In this CT scan, we can see a bilateral subdural hematoma. Is a common finding in abusive head trauma. The acceleration, this deceleration force cause the brain to move within the fixed venous channels in the skull. When the MRI, you can see the subdural hematoma chronic, bilateral. The skeletal survey should be obtained in any child under 2 years of age with unexplained traumatic injury. And this included X-ray and the spines, full ribs and long bones, looking at the fracture. The rib fractures when they are in a baby is a characteristic sign of abuse. Most caregivers will deny a history of trauma, and these fractures are detected on routine of X-ray. Regarding retinal hemorrhage, it must be remembered that they are small. They can be absorbed quickly, so it is important to perform the fundoscopy before 24 hours. Retinal hemorrhage are also found in another cause, such as accidental trauma, anemia, leukemia, and meningitis. Therefore, they are not pathognomonic, and their absence does not rule out trauma due to abuse. The shaking baby syndrome is used to describe patients with subdural hematoma, retinal hemorrhage, and diffuse brain injury from vigorous flu, shaking an infant or young child. The mechanism of trauma is produced by rapid and repetitive flexion, extension, and rotation of the neck of the head and neck. The rapid movement on the brain, strictly the skull, can shears of the vessel, leading to bleeding around of the brain. Baby's heads are large and heavy, and the neck muscles are still too weak to support the head. Due to the absence of external cranial lesion, abuse is not usually suspected, so the incidence is inserted. Sorry. Sorry. Okay. When we suspect, we must first rule out other causes that can give similar findings, such as accidental head trauma, rear trauma, bleeding diathesis, congenital condition, etc. Surgical treatment depends on imaging finding. In the case of dural hematoma, evacuation and washing of the hematoma may be sufficient. In the most severe case with severe edema, the initial treatment will consist on the first or second line, the medical treatment. And if it is not effective, it may require a cranial decompression. The inexperienced and unsuspecting physician may not recognize injuries caused by child abuse. Also, when the diagnosis is unclear, the physician should exercise restraint until the evaluation is complete. For the management of the abused child, an interdisciplinary approach is recommended. The complication from child abuse can be very severe, with great immobility of death, blindness, attention deficit, development delay, intellectual deficit, sensory deficit, motor diffusion, growth retardation, feeding difficulty, seizure, behavioral and education difficulty, etc. Therefore, the prevention is the key. All healthcare providers must work together to educate the public on preventing child maltreatment, increase crying in the main trigger for abuse head trauma. Recognition and education of high-risk caregiver will reduce the incidence of pediatric abusive head trauma. So to conclude, we can say that head injury are one of the main causes of morbidity and death in infants, and child abuse is among its main causes. Retinal hemorrhage are extremely important for the diagnosis of child abuse. However, its sensitivity and specificity are poorly estimated. Subdural hematoma is a common finding. The solution to prevent abuse head trauma is education caregiver and training healthcare provider to recognize the sign and symptom. Preventing mental health care is the best option to reduce the child abuse. Thank you for the attention and apologize for my very bad English.
No problem. That was a very nice talk. That's a difficult topic to cover. I wonder, how much do your colleagues in pediatrics, some centers there is a specialty within pediatrics that addresses just these cases because they're so difficult. Do you have that type of collegial relationship, or do you have to take a lot of this on yourself and within your practice?
Romina, is about the multi-professional team you have at Garahan. Probably the image is freeze. I'm not sure that she is listening.
Maybe other faculty could comment. How is it done at your various places? How much does neurosurgery have to do, and how much is it taken care of by others? Because some people say that because we're surgeons, we don't want to be involved in contentious interactions with families because we inherently do things that have real risks of having a problem, and we don't want to have a contentious relationship in the event of a complication because it sets the stage for, you know, litigation or things like that. Other places don't embrace that point of view. So I'd be interested in how it's handled at your centers with regard to evaluating children and determining whether or not the story is viable and is likely accidental versus an inflicted injury.
Could I go first then?
Please.
Yes.
So, you know, usually we become involved when we get neurosurgical referrals. So somebody will call us. So you get a phone call and, you know, on the other line, it's a story about a child that either had seizures or has become unconscious or may have some scalp edema or a scalp fracture. So those children actually initially come to us. Not all of them, but those will come to us primarily. So they become our children. And then what we do is when they arrive, the history often is inconsistent. And then we have a system in place in the United Kingdom. So it's a national system where anybody under the age of 2 years who has got a traumatic injury, it doesn't have to be just brain injury, even a traumatic body physical injury, automatically gets into the child protection pathway. And that means that the consultant in the emergency department calls the pediatrician on call, and the pediatrician then becomes the primary investigator for the child protection. We would continue to treat from the point of view of the head injury, so they would be admitted to neurosurgery ward, neurological observations, surgical treatment, investigations as required, but simultaneously they will start a conversation with the parents, with the carers, taking detailed notes. There is a pro forma, which is mandatory by Act of Parliament, where every child that comes with suspected head injury has to have that form filled, detailing the injuries all over the body. So a complete physical examination with all clothes removed and detailed markings of all scratches, anything that doesn't look normal, bruising. It's detailed so that it can then be subsequently used for legal purposes. All of that is done pretty much at admission. A dictation of all of those findings is dictated in the emergency department or very soon after by the pediatrician or the person responsible, so that there is a record of all that has happened in a sort of real time. After that, of course, the ophthalmologist is a crucial person, and you know, your leaders, you know, pointed this out and emphasized it appropriately, that we should get an immediate ophthalmology assessment. Now, that often is not possible. And so, for example, we are the second largest, actually, we are the largest single trauma center for pediatrics in the country, yet we can't get ophthalmologists in the middle of the night sometimes.
Of course.
So there's other kind of logistic problems to getting it right, but we would get it within a few hours. And then they would then tell us whether there is retinal hemorrhages or not.
That's a great summary, Guirish. Nelci, how about Sao Paulo? And then Dr. Soleman, how about Basel? Do you have help, or do you need to do much of this yourself as neurosurgeon?
Should I answer, or Nelci, we do go?
In São Paulo, we don't have this child protect pathway. The neurosurgeon, when we receive in the emergency room some trauma, subdural hematoma, or something that have some suspicious, we just call the pediatrician and the team is involved. We just need to signalize that there need more attention. And the social worker and psychologist do their job and try to investigate. But it's not a neurosurgeon that is responsible for this team at the beginning. But always we are involved, and we need to put our report and to write down what is suspicious or not. For example, some of the family tell us one history, the second people tell another history, and there is some divergence between the anamnesis and the findings. I think the most important find is like that. There is one anamnesis and a different child with much more severe trauma that are telling us. I think it's the most common. But probably we are not doing very well our job. Probably we lose some of these diagnoses because it's difficult for us to understand that the non-accidental trauma is real, and the parents or the caregivers can do such difficult trauma for the children.
How about Basel?
Yeah, so in Basel we have a team which is dedicated for that. Like you said, we have one pediatrician who's in charge of the team. It's a social worker, it's a psychologist. And of course, they get involved once in the emergency department there's some suspicion. And we neurosurgeons only get involved if there's something neurosurgical. And then we have to give a statement. For example, if we did burr holes, was there blood? Was it only hygroma? And of course, they do a full skeletal exam, they do eye exam, etc. And that's something that we don't need to take care of. We just give our input, but there's a dedicated team, and also one pediatrician he's a pediatrician, but he's specialized in abuse. So that's like his job in the hospital, and he's like leading the team. So I think in Basel it's quite well organized, and everybody knows what the role is. And then once the suspicion is there, then there's also a machinery where you have families who take care of the kid, etc. So yeah, it's quite good organized.
Very good, very good. Lynn, could you share with us, because by then I think we've heard everybody's approach to SIWORA, but I also want to turn to the questions. One of the important questions that's been posed has to do with outcomes of SIWORA and why external immobilization. So would you like to tackle that, or would you like to tell us about abusive injury, or both?
Yeah, okay. So I'll tackle first the need for the external immobilization. Okay, so they did in 2005, they did this meta-analysis of a lot of articles, and they found out that those who wore external immobilization for only 8 weeks had a recurrence of around 17%, versus those who wore it for 12 weeks did not experience any recurrence of the SIWORA. Meaning, what is the recurrence? It's more of the neurologic deficits. Okay, so that's why they're recommending it primarily to avoid recurrence. Number two, immobilization would mean that the secondary injury would be prevented, and the worsening of the deficit would also be prevented, meaning the movement, especially if it's the cervical, would be minimized. That's why the need of the external immobilization. Okay, so that's one. What were the others? that I had to.
What are the outcomes and what are the why the external mobilization? And I think you talked nicely about that.
Yeah, so regarding the outcomes, the predictors really are the initial presentation after the injury, and also the MRI findings. So prognosis-wise, they would say that those they would term as spinal cord injury without neurologic imaging abnormality. That means that those who did not present or did not show any MRI findings also constituted more of a better prognosis versus those who had MRI findings. But all of this, we know that had already symptoms of paresthesia or even paralysis. But again, in many of the studies, they would say that the important predictors of the prognosis and outcome or recovery would be the initial presentation of the patient and the MRI findings.
Very good. Let's see. I'm just trying to see if there are any other questions. Nelci, are there any points that you want to make?
Yes, coming back to child abuse, do you like to tell us, Romina, about the Garan routine when you have some child that have suspicious of non-accidental trauma? What the routine is? Pediatrician, neurosurgical, what kind of people taking care? You are mute, dear. Yes.
When I can speak in Spanish.
Okay, translate if you want. Okay.
Thank you. Siempre sospechamos maltrato hasta que se demuestre lo contrario. En ese grado de paranoia.
Every child that, just a minute, every child that arrives with trauma in the emergency room, since we prove that is the opposite, there is a suspicion on the case.
En el caso, siempre comenzamos sospechándolo y el trabajo es descartarlo, o sea, tratar de encontrar otras causas, pero iniciamos pensando en que en todo trauma, y como comentabas vos, que no tenga un relato congruente, siempre sospechamos.
Okay, it's more or less like in UK. Every child that arrives in the emergency room younger than 2 years of age have a suspicious, and the medical question is try to prove that there is another issue behind the trauma. Thank you, Romina.
Nelci, are you okay if I share a case, or do you think there are more questions to be answered?
I think we solved most of the questions. The question about one about what the legal position for the physician. In our case, the physician just need to keep the child inside the hospital until the legal issue is done. Is the only part we need to be partner. Don't send the patient to out clinic before we have all the answers. I hope we can answer your question. Yes, Jeff, you can present the case, please.
So this case is literally quite hot off the press. This is a case from this week, and the story was told. Wait, let me look up exactly right. Yeah, she's 2 years old, okay? And the story was told by the family that the child was on the top of a bunk bed, 2 stacked beds, about maybe 5 feet, 1.5, 1.8 meters high, okay? And that the child fell and temporarily was unconscious, and they brought the child to a local hospital that's about a couple hours away from us, okay? And they imaged the child, and these were the images. These were the images here. At this point, she was unconscious, but she later sort of gained consciousness, but was flailing around. She was moving her right side much more than her left side, and these were the images that were obtained here. So we only have a couple of minutes left, but I think that this case, because she allegedly fell from a height, and we didn't know what her spine was, we didn't know if this story was believable, and she obviously has quite impressive findings on her scan here. I think that this case brings up many of the principles that were discussed today. Now, by my watch, we have about 8 minutes left. And so we have about five faculty members. So what I'm going to ask is, could each of the faculty members, I'll kind of keep a little 2-minute timer here so that everybody gets to have a say. Could each of the faculty members comment on the case? You won't have time to comment on all of it. Maybe you comment on what you would do or your particular task, today, like, subdural, Psywara, induced injury, etc. So, Guirish, could you start us off for 2 minutes? And I'll kind of keep a timer and I'll give you a 15-second warning, okay? What would you do with this, Guirish? Tell me.
So, I mean, this looks like a very acute subdural hematoma with an underlying chronic subdural hematoma on the right side with effacement of the ipsilateral ventricle, midline shift. I can't see a fracture, but if you move the bony windows, we can tell whether there's a fracture or not. Let's see. Yeah, there is, no, that's a coronal suture there. So it doesn't look like there's a fracture there.
We agree. That was our impression as well.
Correct. So this is a unilateral fracture, unilateral injury. It's less likely to be the sort of shaken baby syndrome, which often you see bilateral subdurals. Of course, sometimes the other side subdural may not be visible. You can see there's some blood in the tentorium. Can you go to the basal cisterns, sorry, and the posterior fossa? Okay, so there's no bright spots there. We're just trying to rule out. I mean, this is definitely trauma, is that right? Because sometimes trauma can hide a vascular lesion.
Yeah, all we know is the story we were told. Fell from a bunk bed. Okay, you got 15 seconds left before we move on to Dr. Soleman.
Correct. So this would be, if the bunk bed was the second floor, then it's possible. If the bunk bed was less than 1 meter in height, this would not be a consistent explanation. We have to think about the floor, whether a cement floor or carpeted floor. I think all of those would make the decision. In terms of treatment, I would definitely consider a craniotomy, evacuation of subdural, and either a loose bone flap back or decompressive craniectomy.
Okay, and we'll leave it there. So, Dr. Soleman, your 2 minutes, please, on this case.
Yes,
anything you want to talk about, share your wisdom.
So I agree with everything that was said, but I think what is to draw attention to is that there's a chronic subdural hematoma, and on it acute subdural hematoma. That's what it looks like, and that's not a finding that is very typical in a 2-year-old. So I think we need to consider that maybe this is not really a fall, even though it's not bilateral. In old people we see these images, but in babies less. So just to point that out, I think for the treatment, I agree. I would do a decompressive, probably a decompressive craniectomy, and evacuate the hematoma, and then we would need to go for further diagnosis and see the story a little bit better.
Since you covered subdural, I'm going to throw 2 quick questions.
Yeah.
Could the dark blood be hyperacute?
It could.
Okay.
Yes.
That's 1. And 2, do you think this is sinus bleeding? And if so, does that impact the extent of the clot that you take out, that the craniotomy you turn, or anything like that to avoid hemorrhage in your face?
I think that's a very good point. It could be sinus bleeding, especially since it's also in the falx. The craniotomy, we never expose the sinus, and I would be just prepared with the taco seal, spongostan, stuff like that to be able to contain the bleeding if it's a sinus bleeding. Difficult to say from the images, but you need to be prepared in the OR, and I would take 1 centimeter away from the sinus when I do the decompression, just to be sure.
But definitely operate, correct?
I would, yeah.
Yes. Okay, Romina,
Yeah.
what would you do? You're muted, Romina. What are your
Okay.
thoughts? Maybe, what about the spine? What about abusive head injury?
The question, please.
What do you think about this for abusive head injury with potentially 2 different layers of clot there?
The mechanism.
Yeah. Nelci,
Yes,
can you help me?
The
Yes.
mechanism.
Se puede ser víctima de malos tratos por la imagen, por el mecanismo de queda.
Se corta un poco, pero creo que escuché, Nelci, que sí puede ser un mecanismo por maltrato. Sí, yo concuerdo, sí
Yes.
puede ser. Tiene, porque el Shaking Baby Syndrome no es el único que pueden haber asociado diferentes tipos de trauma. El Shaking más el golpe contra un objeto rígido, ¿no?
Yes, she apologized about the connection. Internet is bad also. She can't understand very well, but she tell us that yes, can be possible. One side can be excluded from the etiology, the non-accidental trauma. Yes.
Okay, and Lynn, how about Saiwara? This baby allegedly fell off of a bunk bed, maybe 6 or 8 feet.
Yeah. So 2 things. First thing first, with this head lesion, lesion, I would like to make sure that the patient doesn't have any bleeding tendencies. So maybe we could get some bleeding parameters thing. Okay. So I'm not sure if there's like subdural hematoma on the left posterior parietal area. So and the different densities would possibly point also to a chronic and an acute thing. So with the terms of the cervical or the spine thing, the physical examination should be very thorough with this patient. Okay, so I think an MRI should also be done for this patient.
Okay, I'm going to stop sharing. Very good. Okay, Nelci, I mean, that kind of wraps up our time, Nelci, or Nor Maria, are there any comments that you want to make to close the session?
Yes, just add something on this case, this double density. I doesn't see any arachnoidal cyst, but when we have hypodensity and hyperdensity, we can think about non-accidental trauma, but can be also rupture of the arachnoidal cyst previously. And just add the craniectomy, the comprehensive craniectomy, bone keep on the abdomen, and ICP monitoring at first.
I've got to jump off, just got a call. Okay, thank you for a great session.
Okay, thank you very much.
Thank you very much.
Just remind the attendees for have the certificate, you need to fill the questions, the MCQs. Linda just tell us we have 1 hour more. The room will be open, still open to receive your questions. Don't rush, keep your time, but send the answer to have the certificate. You have the last word for each one, please. You can start, Soleman.
Thank you very much. Very interesting session. Thank you for having me. It was great fun. Have a nice weekend.
Thank you, Soleman. Romina?
Oh, thank you. Thank you, and apologize for my English. I'm very happy to be here today, but I don't speak English. I'm sorry.
You are improving very well. Don't worry. Thank you very much for coming. Lini?
Yeah. I just saw in the chat box there were still some questions. Do we have time to still address this?
You like to have a few minutes? We have.
Yeah, I'll just answer this ones. In asymptomatic children with syringomyelia, what is the guideline for management? So if it's asymptomatic, sometimes you can just observe it at first and later on do serial MRIs to see if it's progressing. And later on, if it's becomes symptomatic, then you need to do some shunting. And then how do you go about in cases of SCI without radiologic abnormalities? So how do you counsel parents? So with these cases, if the patient is still symptomatic, you need to be able to do the external immobilization to prevent further injury, and then also do another MRI because it could be delayed, the presentation even, and then later on be able to counsel the parents to undergo rehabilitation later on if there is some deficits. And from your experience with children, especially infants, how frequently you have infants and how do you assess the cord injury? So assessing the cord injury in infants, you would tend to see if there are deficits in the movement of the extremities, okay, because it's difficult to address the sensory deficit. So it's more of the movement, how you will observe it. Okay, I think that's it.
Thank you very much, Lini.
Thank you.
Excellent.
Thank you also.
Guirish, you are our senior. Your last words, please.
Just to say, it was a great idea. I think this is a very important topic. It's actually the biggest cause of death now, considered the biggest cause of death, preventable death in the developing world. So I think this is very timely, and I'm privileged to be part of an international group. And thank you to all the colleagues for participating as well. So much obliged. Thank you.
Thank you, Guirish. Noor Maria.
Thank you very much, madam. It was a real honor, madam. Aside from the case that we have just discussed about the subdural hematoma, where since we believe that in that age group, non-hematology is very important when we have a patient with with the subdural hematoma, and it seems like especially if there is blood of two different ages. But madam, what's the view of you and the panel regarding the incidence of sinus thrombosis causing subdural hematoma, which is indeed a possibility in the adult patient, that there is because we were talking about the sinus, that's why it came into my mind that we should also discuss this, that do you think that what's your view about supersatural sinus thrombosis leading to subdural hematoma in the pediatric age group when you compare it with the adults?
Two comments, Noor Maria. Venous thrombosis in child in brain traumatic patients is very, very rare, is exceptional. It's not like in adult patients that you have a thrombosis and you have secondarily the brain trauma. In children, usually if you have thrombosis, you need to think about the cause. Now after pandemic COVID and after vaccination, they have a lot of discussion. What means what kind of thrombosis is linked to the vaccination? What kind of thrombosis is linked to the COVID pathology? I think this discussion will be a lot of more important for the next years, for the next time, and maybe more professionals learning and studying the subject. But thanks for raising up this question of this webinar on brain trauma. Thanks a lot. And for the audience, thanks for being with us, more than 1,000 attendees for all our webinar. And thank you very much for the speakers and friends to give your time and energy for ISPN and World Federation Education. I'm proud to have you all with us. Thank you very much. And next month, we will not have the online meeting because we will be in Singapore for the ISPN annual meeting. But in January, will be epilepsy surgery in children, the last Friday of January at the same time. Thank you very much for being with us, and see you.
Thank you.
Thank you.
you.
Thank you very much. Thank you.
Thank you so
Bye-bye.
much.
Bye.
Pleasure.